Okay.
So I guess the first thing to say, Gerhard, is thank you very much for the invitation. It's an honor and a privilege to share some of these experiences with previous Trinity members. It's actually harder to do a presentation for non-specialist audience because it's difficult to know where to start, but I hope this is useful.
Just one second. Can I ask you one thing? Is when you start, yes. Could you tell us a little bit about your path in your career?
Yes.
Because especially for students, that will be very helpful.
Good idea. So I've got that in the next slide, actually.
Oh, okay, so, perfect.
So this is just to say there's no financial disclosures. The picture on the bottom left is the old Royal Infirmary, about 200 years ago or more in Edinburgh. And the top right is the modern Royal Infirmary, because the old one is very expensive apartments, as always. So in terms of my path, I did med school, half and half, UCL and Cambridge. I went back to London after my first house office a year, which in modern language for Angelica is the foundation year. So back then you used to do 6 months of general surgery and then another 6 months of general medicine in your first year. And then you would enter what's called basic surgical training or basic medical training if you wanted to be a physician. And at that time, I was quite lucky to get into the rotation at Guy's and St. Thomas's, but it didn't have neurosurgery. So I went to the director of the rotation and I said to him, hey, there's no neuro in this, but I really want to stick to this rotation. Will you give me a break to go and do 6 months at UCL National Hospital for Neurology and Neurosurgery at Queen Square? And he said, sure. So I went back a few weeks later and I said, okay, great. You promised me a gap. I've got the job. Now can I go? And he goes, oh dear, I assumed you wouldn't get the interview. So now I have to rejig the whole rotation, which he was very kind to do. So this system no longer exists between basic and higher surgical training. It's been rejigged, and I think to the detriment of training, but never mind. So at the end of that, one obtains the membership of the Royal College of Surgeons. And then having rotated through a few surgical specialties, one would choose the specialty they want to stay in. And I tested neuro, I liked it, and I thought, okay, fine, I'll do that. So I entered higher specialist training, and most of my time was spent in London with a sojourn in Oxford. But the rotation, I left Oxford to go back to London because it was bigger units, busier, and bigger exposure, especially at King's and St. George's, which also rotated through what was Hayward's Heath at the time. The unit since then moved to Brighton. And then you finish your training, and it's very long training in comparison to other countries. I have to say the British training system is 6 years medical school plus minimum 10 after that. So it was 16 years or so before I finished training like anyone. And on top of that, it's customary to do these days what's called a fellowship. And a fellowship is not an exam like the exit exam where we take the FRCS, Fellowship of the Royal College of Surgeons. When we call a fellowship, it's a bit like the postdoc for a PhD, but effectively it's an immersion of subspecialized training in one topic in particular. So I chose to do spine. And for that, I went and spent some time in Munich, which I think is one of the best departments in Europe. And then also in Oxford, but this time with the orthopedic spinal team. I just wanted to go to the dark side for a little bit. So we call the ortho spine dark side. They call us the dark side. So having seen both dark sides and both bright sides, if you like, I was able to kind of merge experiences and create my own way of thinking and working. Of course, I have to mention that I spent some time in Tokyo doing skull-based work.
That's where we met.
And that's where we met with Gerhard. And it's already 10 years, Gerhard, isn't it?
Really? Oh, really?
Already 10 years, yes, I think so, if not more. but it's at least 10 years or maybe 11. So that's my path. And now I'm in, I moved to Edinburgh, rightly or wrongly. I do miss London from the hustle and bustle point of view, but I don't miss the commuting. So my current involvement is that I have set up a spinal trauma or spinal fracture clinic, which runs weekly. I have a weekly complex spine clinic, which includes also spinal tumors and so on. I have a trigeminal neuralgia clinic, which is facial pain. We can touch on that a bit later. And of course, whatever comes through the door, we call it general neurosurgery. At the national level, I've been chairing and leading the SABIN, Scottish Acquired Brain Injury Network, for the last few years. And internationally, I am very much involved with the European Association of Neurosurgical Societies, and took over as president in October. But I've been involved with them for well over 10 years, 15 years. But I also teach for other foundations, such as the AO Spine Foundation, the Global Neuro Foundation, and the World Federation of Neurosurgical Societies. In fact, we're going tomorrow to Colombia to the World Congress. Hopefully travel will not be too tiring. But that's my path. In terms of neurosurgery in the UK, we're quite different to other countries in that we have what's called a centralized model, and there's only about 30 to 35 departments in the country that deal with neurosurgical conditions. There are, of course, just as many orthopedic spine units, but as regards proper neurosurgery units where you do both brain and spine, there's only 35, which means every unit or every center serves a well-defined catchment area, and people cannot cross from one area to the other. So if a patient is in Birmingham and wants to go to London, they're not allowed. Whereas in other countries, if you're in Berlin and you want to be treated in Munich, you just book and go. And that's one other particularity of our system. We have a protected patch. We kind of have good follow-up of our patients and our results, but it does mean much longer waiting times. This is just to show you how 60 years or more, when the neurosurgical unit in Edinburgh was set up by Norman Dodd on the left, there was no MRIs, there was no CT scans, there was very little. And I think they had skills we don't necessarily explore much today. And that means, for me, one of them means the art of illustration, because this is an operative note that Norman Dodd himself constructed after an operation. Whereas nowadays, everything has to be typed into a computer. So nobody draws much anymore. It's a lost skill in some ways, and it's quite a problem in the future, because surgical illustration is a field that needs the collaboration between a surgeon and an artist. And we recently published a paper on Norman Dodd's art and science in surgery, but I wonder what will be the story in 50 years time or 10 years time. This is Henry Marsh, outspoken British surgeon. I worked with him at George's. He liked the sound of his voice quite a lot. We had a love-hate relationship, but I learned a lot from him, and I think he popularized neurosurgery to some extent, and he still does so by giving talks on other non-technical issues anymore. But what is neurosurgery is what I'm leading towards, and I'm showing you here some everyday vignettes that Angelica will be looking after in a few years. And if we go from left to right, that is a very bad situation to be in. If you have a fracture and a dislocation in your cervical spine with spinal cord injury and swelling or edema, this person is probably never going to walk again unless you catch them really, really early, which again depends on how quickly ambulances and district hospitals can scoop and run and scan and then run to the other specialized center. And I am a little bit disappointed to admit that MRI scanners in most UK hospitals shut at 5 p.m. And after 5 p.m., if you present to a district general hospital, they will probably try and transfer you to the regional neurosurgical center, which of course adds time to the diagnosis time, etc. But the recent introduction of major trauma centers in the UK, which is in England, it was 10 years ago, in Scotland only a year ago, means that there is a well-structured network that picks up trauma, and instead of going to a district general hospital, it diverts immediately to a major trauma center. And I think that's been a major improvement in how things run. Middle one, I had a childhood friend who unfortunately dived into the shallow end of a swimming pool. He's a TV director now, but he's been in a wheelchair ever since his 18th birthday. And it's very sad to see that this happens every day around the world still. But these are everyday vignettes. What is neurosurgery? It's a lot more than what it was 20 years ago, and a lot more than what it was 50 years ago, and so on. I put spine first because it's one of my own special interests, but also because it's one of the few subspecialties that keeps growing, whereas the others are under threat. Vascular, for example, is dealing with aneurysms or bleeding points within the brain, but with great improvements from endovascular techniques. In other words, putting little probes through vessels and going to anywhere in the brain through that technique. It means that neurosurgeons have allowed radiologists to take over a lot of that field. And while in some countries, a surgeon is allowed to learn both techniques, in other words, the endovascular as well as the surgical, open surgical, in other countries, there's a territorial war as to who should do this. And the same war, if you like, or fight, exists in the general vascular field, for example, in the abdominal area or abdominal aneurysms, and indeed in the cardiac arena. I'm sure Roland can tell us about the issues there between cardiologists or radiologists and cardiac surgeons. A big field of neurosurgery still remains brain tumors, and those can be either primary, in other words, originating from brain material or substance, or secondary. Secondary means they have spread from another part of the body to the brain. Primary brain tumors originating from brain substance very rarely spread outside the brain. And then, of course, there's a lot of benign tumors or cysts, like Adrian mentioned, which won't necessarily have malignant biological function, but simply their presence and pressure on brain structures can cause significant symptoms. And some of these are in the surface. In other words, they're easy to access from the top. Some of them are deep, which means we need to invade certain distance. And some are from the skull base, in other words, from the bottom up. And the techniques for accessing different parts within the skull are quite varied. And that is where Gerhard, the Japanese, were extremely good. And I came to learn from them 10 years ago. Now, neurotrauma, I have a lot more on neurotrauma if we get to it at the end of the presentation. But you would think that in 2022, trauma is not a big problem, but in fact, it's a growing problem. There are two types of trends in trauma. Or we have societies where seatbelts are not yet compulsory, or riding a motorbike without helmet is still seen as cavalier. And then, of course, we have trauma in older population. So it's a lower energy trauma when you slip and fall down the stairs or on ice because of weather conditions, and it can easily cause devastating injuries. In reality, a severe head injury, in other words, where someone is thrown into coma because of the impact, that's called severe head injury. The prognosis is very varied and can be quite bad. For those who survive, life has changed, abilities will be diminished, and they might need round-the-clock care. But now it's becoming more obvious that minor head injuries, where someone suffers repetitive small concussions or even a single one, that can lead to more executive function type problems where concentration, calculations, decision making can be quite impaired, and even that is difficult. In fact, probably more difficult to handle, because this person is absolutely fine. They look fine, they talk fine, they walk fine, but then when they have to do something, you realize they are forgetting things or doing them different to what they used to. CSF disorders refers to cerebrospinal fluid disorders, which is the brain fluid within the brain and spine. And sometimes we have conditions that allow too much of that fluid to be maintained, which creates more pressure inside the head. It's something called hydrocephalus, for example, where a diversion needs to be created, either by creating an artificial pathway with a shunt and a tubing system, or other techniques where we make new holes or openings within the brain itself to allow improved drainage. Functional neurosurgery is a very, very exciting field from the science point of view, because it involves surgery for a few things. For example, surgery for epilepsy to stop epileptic disorders. Another one is the implantation of deep brain stimulators, which are small, very small stimulators, quite deep in the brain, and the indications for those include movement disorders such as Parkinson's disease, or some sort of dystonia, abnormal body movements. But the indications seem to be expanding. Some of them are still in experimental phase, but they seem to be gaining ground towards mainstream options. And that might include, for example, psychiatry, or even some type of dementia or obsessive compulsive disorder, or even blood pressure. But all these things are still yet not in the full mainstream, apart from the Parkinson's. So it's a very exciting field on the scientific side of things, and not so much in the technical side of things, according to some surgeons. Now, pediatric neurosurgery involves all the subspecialties within the pediatric age range, which varies from country to country. For example, I think in England, it can be classified as a child up until 18, whereas in Scotland, you're transferred to the adult services at the age of 16. Peripheral nerve is the subspecialty that deals with nerve problems outside the central nervous system. In other words, not inside the brain, not inside the spinal canal, but beyond. And that's when we have, in the simplest form, for example, carpal tunnel syndrome, or ulnar nerve compressions at the elbow, or brachial plexus problems. Let's say motorcyclists having trauma in the armpit area, where the brachial plexus nerves are injured. And that is quite a subspecialized field with very few centers in every country. Radiosurgery, this is a situation where a tool has become a subspecialty, and the tool is something called a gamma knife or a cyber knife, which are commercial names, but effectively is high precision radiation with a conformal beam into a very focal point delivered at high energy to affect change. And the indications, again, are quite varied, ranging from tumors to functional, even for the same purpose as the deep brain stimulation in some cases, or even some vascular problems such as arteriovenous malformations, where there's a cluster of vessels inside the brain that can be treated with radiosurgery. So this is not a complete list, but a near complete list of what one can visit in a neurosurgical department these days. For example, Angelica, if you go to your local department in Edinburgh, you might see most of these things. And then, of course, you go to the internet and you ask yourself, how can I become this and that? And you see all sorts of things which might or might not be relevant to your own environment. This is from Florida, but I think the idea is, of course, or the skeleton is fairly standard. Now, I like this picture because it was about a year ago. This footballer was allowed to continue, the goalkeeper was allowed to continue to play. Arguably, should have been taken out because this is a serious concussion. And I have some students working on the guidelines, soccer-related guidelines and other sport-related concussion guidelines of care. And unfortunately, you might remember a few years ago when Jose Mourinho of Chelsea had an argument with a Portuguese physiotherapist who went against his advice, and she insisted on a player being taken off the pitch for health reasons. And of course, these players are paid so much money and the club makes so much money that the pressure is that they're always on the field. And the result was that she lost her job. But it's important these days to follow guidelines if they exist. And if they don't exist, we must ask ourselves, what is the best thing for the patient, not for the financial revenue? Because this person may not play for very long, especially after an injury like this. In any case, I think he did fine. In terms of TBI, traumatic brain injury, and its effect on a daily life, without going into specifics, the view that the brain consists of different regions that do different functions is very old-fashioned, very, very old-fashioned, but still in use every day. However, there is evidence that these regions have all got quite extensive and complicated and complex interactions between them. So these territories are actually a lot more, a lot less defined than we used to think. But it is true that if you have a frontal injury, in other words, at the forehead or behind the forehead area, there will be these behaviors of decreased focus, increased irritability, difficulty of expression, sometimes disinhibition, which is very difficult to deal with in families. If you have more of a lateral or injury in the parietal area, again, it depends on the focus and the size of the injury, but you may have difficulty with spatial cognition or perception, difficulty with reading, with interpretation. And then if you have injuries at the back of the head, which is where the occipital visual cortex, there may be problems with blind spots or brain blurred vision. Down here, the cerebellum is the old brain or the ancient brain, more to do with coordination of gait, coordination of speech. So it's quite predictable that anything that involves coordination will be affected, but luckily that is a protected part of the skull. It's underneath, so the direct injury there is less common, but it can be affected by blood clots and tumors and so on. I'll switch a little bit and I'll share a story. So neurosurgery has a reputation that when other specialties call the center and they say, oh, can you give us advice on this so-and-so patient with such and such symptoms, can you take over their care? Neurosurgery used to have a reputation that they always say no. And it's either because someone is too old or too well, and then when you wait a bit and the person who was too well now becomes unwell, then people would joke that, well, now you're saying he's too unwell, so you still won't take them. So when the hell are you ever going to take any of our referrals? And I remember this referral from A&E in South London, when the registrar from A&E, who I kind of knew only by phone, said to me, you're not going to refuse this. So I said to him, try me. And he said, okay, 44-year-old in A&E, he's complaining of headaches, 11 weeks, and he's refusing to take his cap off. And I said to him, why is that relevant? He goes, well, I'll tell you the story. So he had a fight with the registrar. He wanted x-rays. The registrar explained to him x-rays cannot show anything in the brain other than your skull. The guy insisted on x-rays. So the registrar then had to call his consultant. The consultant had the same explanation. Look, sir, there's no point doing x-rays, and I don't see the point of doing a CT either on someone with headaches, because headaches cannot be visible in a scan. This is just not how medicine works these days. And the guy goes, really? What if I take my hat then? And he takes the hat off. And basically, all you could see at the top of his scalp was a cluster of the heads of several nails that he had hammered into his own head. So then suddenly they rushed and did an x-ray. And then they made the phone call. But this poor chap had a psychiatric disorder, and he was, paranoid schizophrenia. And basically, to punish himself and rid himself of evil, he used to hammer a single nail every week for 11 weeks or 10 weeks. But then he ran out of the small ones. So he instead looked in his drawer and found the next smaller was this one. Now, can you imagine? That's an 11-inch nail that he hammered himself into his own skull. And of course, we accepted the patient. And during the transfer, we were all debating, what shall we do and how we're going to take this out? And how is this not going to cause severe bleeding while we're withdrawing them? And of course, the reason why he put them in is still going to be there. So he might do it again the next day. And just to remind you, you don't need to know the details, but there's blood vessels everywhere, including the brain. So these nails must have caused some bleeding, or we assume they would have caused even more bleeding on their way out. So these are the arteries, and these are the veins. And that big one, we thought, what if it's cutting anywhere through these big veins? Because veins are a lot harder to control than arteries. And in the brain, you can't really just buzz them like you can buzz them in the leg or the abdomen, because in the brain, if you buzz something, you don't know if it's going to cause a stroke. So you try not to buzz anything. So we're more used to dealing with bleeding and working around bleeding points, but trying to control them naturally without necessarily coagulating them too much. But with this guy, we thought, oh dear, where are all these nails going through, and what will happen if we pull them out? Because he was getting headaches. So he came and we had them all, we had a scan with a CT and a CT angiogram, and we kind of mapped what was easy to do and not. And I remember having a discussion with Henry Marsh, who wanted to do this way. And I said, no, we should do it another way. And he said, well, I'm the consultant, so we're going to do it my way. It's either my way or the highway, he said. And halfway, the preparation, he comes into the room and he goes, I've changed my mind, do it your way. And my way was very simple. I said, we're going to keep him awake in theater. He had shaved his head for us anyway. We're going to keep him awake, remove them one by one. And if he drops into unconsciousness, then we know something is happening, in which case we need to run to CT, check which is the area of bleeding, and come back. because he insisted that we should do it asleep, but asleep, you won't know anything for 2-3 hours later, which might be too late. Anyway, guess what? Nothing happened. The guy got off the table at the end of the procedure, said, I still got a headache. Can I lie down? And he was totally fine. And we sent him off to psychiatry. Believe it or not, we had then a debate with psychiatry that they refused to take him for the first couple of days because they said, we can't prove that he's not got normal faculties. And our counter argument was, well, who with normal faculties would insert a dozen nails in one's head? But and that argument went back and forth for 2-3 days until in the end, obviously, they realized that they couldn't refuse him, just like we couldn't refuse him. Another one interesting case, and I have consent to share the pictures for this one, is the so-called, so the previous guy was the nail man, and this one is the paintbrush man, where I get another phone call from the same A&E registrar who was collecting his own X-files by this point, and he said, another goodie for you. Look how deep this went, even though he woke up. And luckily, it missed the globe of the eye, the optic nerve. It went through the sinuses of the nose into the temporal lobe on the dominant side, which is useful for speech and production, generation of speech. But luckily, again, no obvious harm. Quite a long one. And he wanted to keep it. He wanted to take it home. So we let him have it. And in the end, if you look, he can look all the way to one side normally, all the way to the other normally. And this is where we do visual fields. We can judge if there's any field cuts, or in other words, dead parts of vision or blind spots. And remarkably, his were completely normal. So yeah, it's strange what you get. But these, of course, not everyday cases. If I remember them 15 years later, it means they left a mark in my memory. Can anyone answer? Does anyone know the answer to this question? Basically, they've all had spine surgery. And I guess, like Adrian will know, well, Adrian, you had brain, but spine is even more common. Yeah. So there are people around us who've had all sorts of treatments for all sorts of conditions, but spinal surgery is the commonest condition in neurosurgery because it's simply usually related to the wear and tear of the spine. So it's a form of arthritis situation. And spine surgery has these 4 aims: to preserve neurological function, if there is already some dysfunction, to prevent its worsening, to alleviate pain, and to prevent, alleviate, or correct instability. Because the spine is obviously it has a contour, and sometimes that is changing. Someone like this, unfortunately, probably will never walk again. This is a tumor that invaded and slowly destroyed that area, and then a sudden change in or sudden impact, like jumping off a step, can cause this, but this is super rare. In other conditions, we have degenerative disc disease. So, for example, you see the gray squares are the vertebrae, in between them are the discs, and in the traditional old-fashioned way, a disc is removed, and in its place, a graft is inserted and held together to create fusion. But more recently, especially the last, well, certainly more than 10 years, motion preservation surgery has been proposed so that this continues to move or slide like a normal joint. But there is a lot of controversy, so we keep analyzing these things. For example, with systematic reviews and meta-analysis, because on the one side, the enthusiasts say we should do disc replacements. The cynics on the other side say we should not do disc replacements. We should do only fusion. And as per usual, the truth is usually somewhere in the middle. But it's interesting that despite 10 to 20 years of data from its original introduction, some NHS hospitals still don't offer that at all, and others offer it routinely. So it's a bit of a postcode lottery still in some scenarios. This is not so much for this audience necessarily, but the elephant in the room in some spinal conditions is whether there is spinal cord dysfunction as opposed to just nerves. And cord dysfunction will present with weakness, with some signs of hyperreflexia, and too jerky jumps, in other words, but more importantly, instability of gait. And you can see the reason I'm showing this is this was the first case that I did in Edinburgh when I arrived as a consultant. Before I left, I went and had a pint with Peter Bullock and others, Adrian, and their advice was, when you go up there, nobody knows you, start with the easy stuff until they get to know you. For the 2-3 months, do easy stuff. Don't take brave cases on, just to gain their confidence. And this is one of the hardest things anyone could do in spine. Even today, after 10 years, I would still think this is probably one of the hardest things that I would see on a day on my list. Because if you look at, so that's the spinal cord coming down, the white behind it and in front of it is fluid, which means there's plenty of space. In front of the spinal cord is the spinal column with the vertebrae and the discs, but this disc has gone out and is huge. The width of the cord left there is less than 1/10. You look at on the horizontal slice how much invasion that involves and how much of the cord is left. And then I did a CT because these are notoriously calcified. And look at that. This was a stone invading into the spinal canal, allowing very little left. So I called my old mentors in London and I said, hey, is this one of these simple cases you said I should be doing? And they all said, oh, someone doesn't like you there. They want to kill you very quickly. And I said, well, I can't refuse this. You know, he's already been admitted for the last 3 weeks. Nobody wants to do it. What shall I do? And they said, well, it's time from either 0 to hero or hero to 0, and time will tell. It's better to be lucky than good. The patient is very, very happy, and so am I about his great recovery. But yeah, it was a stressful start, shall we say. Other things colleagues in spine surgery can do is, you can see here there's abnormal curvature, scoliosis, which can be corrected in different scenarios. Whereas this one, again, is trauma. This is something I'm working on with some colleagues from the European Association, where we are looking at how often is there a missed spinal injury in those presenting with a head injury. And this person presented with a severe head injury, was intubated and anesthetized, kept on intensive care asleep for several days a few years ago. And when he was well enough to be woken up, he wasn't moving arms or legs. And then the penny dropped that, oh, we never checked his neck. Whereas we always say, and then we get the phone call saying, oh, he's not moving his legs. But it's standard practice that you do imaging of the brain and the spine before you fully finish your investigations. And now, of course, this is a lot more understood, but it still happens from time to time. Also here, of course, where we might be caught out. And I think it's in the work we're doing now, we're trying to work out what are the, the pros and cons, what are the patterns of injury, and what are the downstream sequelae of a combined head and spine injury as opposed to isolated injuries. And of course, there is also a debate in everything we do. There's a strong rationale for early surgery, according to some people, and this is good work from colleagues in Canada, which I agree with, that if you don't act quickly to reduce this dislocation here and here, because all that edema is not going to get any better if you don't give it more space, which means you need to decompress, you need to fix, and you need to give it time. There's no real drugs that help. There's a couple of candidate drugs proposed every year, but we haven't got any single drug that is known to help with spinal cord injury. I think it's a Nobel Prize waiting to be given, Angelica, for anyone who might want to do that in the future. And then I'll switch a little bit field and move to 61-year-old secretary, who actually was Norman Dott's secretary. This lady was the very last secretary that Norman Dott, the founder I showed you at the beginning of the Edinburgh unit, was hired. So she was, I think it's in her late teens when she was hired by him, and she ended up in my clinic with facial pain. One of the nice stories she told me is that she used to run behind the professor on the ward round with an ashtray so he could tip the cigarette into the ashtray, which is unheard of, obviously, these days. But left facial pain is sharp, it's electric, very quickly comes on and goes away, but it keeps coming and going. If you brush your teeth, if you're blown by wind, or if you even chew or talk, there's nothing to find on examination. And these patients describe what we call trigeminal neuralgia. And trigeminal nerve is one of the nerves that start in the brainstem but come out into the face. And it's really one of the worst pains to have. And I don't know what's going on here. What can you see on Gerhard? Is it? Yeah. So
yes, I can see everything fine.
Yeah. So the next picture should be. Is it a circle? Yes. Yeah. So basically, yeah, I don't need to spend time about the diagnosis of trigeminal neuralgia, but it's a condition that is debilitating. People cannot work, they cannot eat, they avoid chewing on one side because it's painful, which means the teeth get bad in the meantime, so it gets doubly painful. They get teeth extracted originally, sometimes before the correct diagnosis is made, but they are depressed, high rates of suicide. But there's a great solution. And the solution is either medication or an operation or an injection. I'll show you in a second. But effectively, the arrow here shows how the trigeminal nerve, my mouse is not working anymore, but the trigeminal nerve on that side shows how it's crossed by a vessel, and that contact creates atrophy. And the atrophy leads to loss of the insulation of the nerve, the myelin sheath. And because of that, they get short circuits of electric type pain. And we tend to get this referred earlier than before. And in the past, it was too long. But nowadays, we can. This is one of the operations that Peter Bullock taught me how to do nicely, because he was very good, very good at this. And basically, you want to put a little cushion between the artery that is pulsating against the nerve, causing the demyelination, the loss of insulation. And you can see the picture of one of our cases. You can see the kink in that white structure on the right, which is the nerve. That kink from the artery. Now that artery is being pulled away with a little probe that is not visible on the far left of the picture. But otherwise, it was digging into the nerve, and the padding in between is enough to stop these things overnight, which is good news. Another option is to insert a needle through the face into the Foramino Valley, which is in the middle of your screen about the right side, excuse me. And this is one of the pictures that every medical student has to memorize in the first or second year. And at the time, we always thought, what's the point? Who needs to know all these things? And whenever are you going to use them? Well, luckily, I get to use them now because I need to enter the Foramino Valley. Sorry, my mouse is gone. But can you see Foramino Valley, which is about halfway on the right? If you follow the line into that little hole, we basically need to enter from point 3 on the screen forward in a direction towards the eye, but imagine an inverted triangular pyramid as the target. But of course, we did with X-ray guidance that can show the entry point, and we need to finish in that position. So again, it's a technique that can be done under general anesthetic very quickly and safely instead of the operation. This is a sort of setup, but it's amazing how someone who's drugged a lot, drugged into drowsiness, if you like, by severe polypharmacy, many drugs, can be treated with 1 or 2 techniques and the pain disappears, not always, but most of the time. And then hopefully the drugs can be weaned to 0 slowly. But yeah, so I'll stop there because the rest is head injury specific stuff. The mouse is back, good. So we could stop here for now if you want, Gerhard.
If you like, yeah, this was a fantastic overview. I mean, it doesn't mean that by listening to it, we can do what you are doing. That's far from it, but I know much better what you're doing. So if you don't mind, I have prepared 2 questions which I'd like to ask you, if it's okay. I sent them to you by email. And the first question is kind of much more down to earth. You know, most of us here are essentially sitting jobs. I think you probably stand a lot during your operations, I guess. But I have so many friends who have spine operations because of lower back pain. And maybe you do such operations as well. So my question to you is really, you know, what causes this lower back pain when you sit too much? And is that an active area of research? And what can we do to prevent it? And what are you doing for such operations?
Thank you. No, I got your email this morning, and it's true that this is indeed an everyday problem, and I see a lot of patients with that. There's not a clear answer, the truth is, because back pain is not a single pathology. You know, it's a multifactorial problem. There's several models proposed. The latest model, which is popular, is something called the Psychosocial Model. So it allows some physical explanations. For example, if you have advanced degeneration of your discs or your joints in your back, it allows for a social situation where, for example, people under a lot of stress at work are more likely to suffer back pain than others. And of course, it allows for psychological factors as well that may exacerbate the perception of pain because of the way people can or cannot manage the pain. So based on that, we know that surgical treatments for back pain are not very successful. So most of the spine surgery that gets offered is not for back pain, it's for leg pain, because the nerves are in your back, but the nerves supply the legs. So we operate in the back to decompress and free pressure from the nerves in your back that go to the legs. But to operate for back pain per se, the results are no better than 50 to 60%. So that's quite low. Whereas with nerve pain and sciatica, for example, you know, sciatica being the nerve pain down the leg, the results are 90%. So to go from 90 to 50 or 60 is not the same. And there was a trend where a lot of people used to be operated for back pain maybe 15, 20 years ago, but that has significantly changed. So it's a bit of a situation. And in fact, I looked at when I got your email this morning, I managed to find something in an old presentation to some local orthopedic doctors, which was dispelling some myths about spine surgery. And if you have, they're very short. It'll make you laugh a little bit. The first one was, if you go to a surgeon, he or she will put you under the knife. And does anyone here feel like that? You never know. But the truth is, at least for my specialty, is that is a false perception. Most of people who present to a spinal clinic, a vast majority, will not need surgical management. Most of it will be dealt with either physiotherapy or with appropriate medication for a short period of time, because often bulging discs will shrink. 80% of bulging discs will shrink within 2-3 months. There's always a risk-benefit analysis, and there's always the cost effectiveness and the socioeconomics. But if you go to a good center or a good colleague, I think this is the trend. The other one, which I get a lot here in Scotland, the public, every time they come to clinic, think that they have a 90% chance of paralysis. And I don't know where that comes from, because the reality is that the risk of paralysis is way less than 1 in 1,000. And of course, it depends what you do. In the case I showed you that I had to do in my first week in Edinburgh with a calcified thoracic disc, the chance of paralysis there is 30%. That's why it's considered a very risky procedure. But every other disc in the lumbar spine or the neck, the cervical spine, the chance of paralysis is way less than 1 in 1,000. So this is not an everyday risk. And then finally, or not finally, but the third one is surgery for back pain or not? And while I told you 90% not or 80% not, it's partly true, because most of the time, back surgery is for leg pain from a pinched nerve in the back. But some back pain can be treated surgically too, bearing in mind there's too many causes, and we need to allow for some specialist investigations. Now, if you go to your doctor and you say, I've got knee pain on the left, there's only one left knee. And that's the presenting problem. You're going to investigate that knee. You might do X-ray, MRI, or whatever, right? But if you go and you say, I've got back pain, we have the problem that we have some 32-something vertebrae. And at each level, if we take this single segment, a segment of the spine consists of 2 vertebrae and the disc in between. So if you look at a single segment, unlike the single knee joint, here we have a disc, which is a joint, the facet joint on one side, which is the one connecting the vertebra above to the vertebra below, as if the dominoes are stacked up, they're connected on each side by a facet joint. So this one on the lateral view, but top down, it's this thing here, and another one on the other side. So already we're talking about 3 joints at one level times 33, and you try and work out where the back pain is coming from. So that's why I think the physical model of back pain is not so clear unless there's a very obvious abnormality on the images. And on top of that, we have, of course, the muscles, the ligaments, the tendons attaching to the spine. We have the outline, if you have symmetrical contour or whether you have scoliosis and so on. So in some ways, the way we sit definitely affects. We have sedentary jobs. Are people at a desk job more at risk of back pain than others being more physical? Well, I used to think yes, but I'm less and less convinced because now we get people coming to clinic who are athletes or people who are doing manual work. So basically, it's a 21st century condition, I'm afraid. Definitely posture is an issue. We shouldn't sit for too long in the same position. Every 20 minutes, we should ideally change our position, or at least break the mold, get up and sit down again. We should sit symmetrically. Those of us who do computer work should make sure that our feet are resting flat, that our hands are resting flat on the keyboard, and avoid awkward angles. Also for the neck, the screen is at eye level height as opposed to too high or too low. Those who work a lot on laptop will have problems with neck pain because you're always looking down on your lap. So it's better to kind of have it more horizontal to your gaze. And so these are the sort of very basic things that we all neglect from day to day. And in relation to that, if you have back pain, go and see an orthopedic doctor or a neurosurgeon. Well, this is an old style perception, and it varies from country to country and region to region, because it doesn't matter if you're a neurosurgeon or an orthopedic surgeon, as long as you're a dedicated spine surgeon. If you have subspecialized to do spine with or without other things on the side, that's fine. But if you are doubling in spine, as opposed to being a dedicated spine surgeon, I think that's a risk. And in the private sector, at least in the UK, this is a trap, because neurosurgeons go and do private once a week outside the NHS in their local private hospital.
Mm-hmm.
But most private hospitals outside London do not have intensive care, which means they cannot do cranial work, which means they can only do spinal work. And therefore, you get people who don't do much spine on the NHS offering only spine privately, which I think is a conflict of interest. Why are you offering your secondary interest to people who are paying on top for better service? I think there's a problem there. And unfortunately, it's not solved. But yeah, that's the answer to your question, I guess.
Okay. Oh, that's a
Here's number 5. How about this one? The answer is in this. I recommend you see this. We can either look at it maybe either part of this session, but otherwise, if you go to Mitchell and Webb, the comedians, and type in this, you'll find a lovely. I'll put it in the chat box.
Oh, thank you.
Maybe Gerhard, who is in charge of the session, if we have time, you can play it later.
We can. Well, everybody can look at it afterwards.
Yes, exactly.
Okay.
Right.
If you have other questions, maybe Angelica, ladies first. You're the only lady here, as far as I can tell. And it's also Ladies' Day, more or less, now, I think so. Yeah. Why don't you start with the questions?
Yeah, thank you so much for the talk. It was really interesting. I really enjoyed that. I actually had 2 questions. The first to do with thoracic myeloma, I think it was, that you had, that you said it was one of the hardest surgeries that you've had. How do you balance kind of the difficulty of the operation and deciding whether to operate or not, and balancing the patient's expectations for what they want from the surgery and the outcome, if that makes sense?
So yeah, the case I had showed is a calcified thoracic disc, not myeloma. Myeloma is treated non-surgically, actually, but the thoracic disc in other words, a disc in the thoracic spine was the one we saw earlier. So yeah, this is a conversation we have every day. Obtaining consent, in other words, agreement for an operation from any patient, assumes that we give them enough information at a level they can process that information to make an informed decision. And it sounds easy, but actually we have to take into account that, Adrian will correct me, and Tom, because in the UK, the average reading age, I'm told, is about 12, right? That's what we're told in the hospitals, that the average reading age is 12. So when you see your patients, don't use fancy words and fancy diagrams. Make it simple and safe so that they can understand what you're trying to do. Now, I think a lot of this goes way over the head of most of our patients. So the task is make it super simple and give them time to understand. We also know that from a consultation, they probably retain only 20-30% of the information you give them, right? So the more we bombard patients with information, the less likely they're going to remember it. And this is it's also a legal minefield when later they come and they say, you didn't explain this very well, and it didn't go very well. And then you can say, well, I did, and you signed the form. But the judge will say, well, signing a form doesn't mean anything these days, actually. So the balance is reached, first of all, in your head. Do you have enough experience to do it? And if you don't, then you shouldn't do it. You should ask someone who has more. Of course, then how do you learn? How do you become experienced if you don't do it? And that's where training or supervision and mentorship come into play. And our system used to be very good at that. I fear that our system now is declining. Things have changed. And I don't know how we're going to fix it anymore. But it's important to maintain mentorship. So I think it's a balance of risks. You need to quote your own statistics. A lot of people quote the statistics that are available in the published literature, but that's not necessarily what the patient is asking you. The patient is there in your department, in your hands, asking you what is the risk. So what's the point of me quoting the results of some published paper that doesn't reflect my own experience, right? So we need to be honest and give them our own rates of complications, not the ideal ones that someone published. Mm-hmm. Unless you publish your own, in which case stick to your own data. But I fear that consent is a complicated process. It's oversimplified on the one hand, and also the General Medical Council keeps complicating it by coming up with new guidance every 2-3 years, because every time there's a new case in court, they keep changing it a little bit. And because we have case-based law in the UK, they seem to be reactive to change to new cases, but there is very much confusion, I would still think, in the complex cases. Now, what does that mean in the long run? Well, it means that some colleagues are risk averse. So we see it now where colleagues who would do cases in a different environment are saying, I'm not doing this, let someone else do it. And I'm seeing this, and it's a little bit annoying, because you may end up with a huge waiting list of your own patients plus those of others, because they're risk averse. Mm-hmm. So I don't know. It's a complex matter. I don't know the final answer to that.
Yeah, thank you for the explanation. Yeah, I guess there isn't really one simple answer. And my second question was to do with technology, and I think you talked about deep brain stimulation as well. How do you feel like the role of a neurosurgeon is going to develop in the future with the exponential development of technology?
I mean, neurosurgery has always been technologically driven, and we are hand in hand with. We need equipment. We need good technological aids in our work, because we work on structures that, if we take a slightly wrong access route, we may cause damage. So we are very much, I think we're one of the first to use what's called computer-guided surgery or image-guided surgery. So it's a bit like the sat-nav system in a car, where you scan a patient, you then match certain coordinates on the patient in real life to the scan, and then you can you can use it during the operation to navigate. And this can be done both for brain and spine. And I know now that orthopedics now started using the same thing for doing a knee replacement or even a hip replacement. So this is invading or has invaded surgery many, many years ago. Colleagues in abdominal work, they use something called the Da Vinci robot, where certain maneuvers that need minimization of the physiological tremor can be performed by you being in a little console, in a little cubicle away from the patient, doing the procedures with your hands. But before that, you've inserted the instruments inside the patient, and then the computer or the robot minimizes those physiological tremors. It's obviously more complicated than this, but these technologies here to stay. So we have technology of now robotics coming in. We have technology of visualization, like microscopes. In neurosurgery, everything we do is with microscopes. I mean, I remember in the old days, we had to go and buy some loupes, which are basically magnifying glasses and to wear. But I used to get neck pain all the time because with loupes, you need to look down. And we've done some work on ergonomics as well to prove that if you're using a microscope and your head is in a neutral position, you're looking ahead, is much better than wearing loupes where you still have to bend forward. I don't know if Roland, you have similar experience, but I know loupes are more common in cardiac surgery than in neurosurgery.
Yes, I mean, I use this for coronary bypass surgery, that I have the glasses with the loupes. But I only use this really only for the anastomosis of the coronaries. I could not do it without, because it's so small that you can't do it with precision without these loupes.
Exactly, yeah. But from my point of view, I find loupes give you magnification of what, 3 times, whereas a microscope can give you 30 times. So the microscope is more bulky, but we have neurosurgery specific microscopes, and you see things 30 times bigger. What new technology may come? Well, I think artificial intelligence will come in, where MRIs will be reported by a computer in the future, I think, and simply vetted by a radiologist, and that might solve the radiology crisis. Some procedures may well be done by robotics, but I think there will always be a doctor responsible for it. I would hate to think that we are completely redundant, but you never know.
Well, thank you so much for answering my question.
Welcome.
Roland, do you have questions? I'm sure you have.
Just a comment. You mentioned the robotic surgery. This was a very big issue in cardiac surgery, and every hospital who felt it to be important bought a Da Vinci robot. Yeah. And this was honestly said a horrible disaster. I mean, I saw too many people die because of that. And that's what you mentioned before about technology and how do you say this, advances in technologies that specifically also in cardiac surgery. I see in cardiac surgery since the time when I was started. I mean, remember the first open heart surgeries more or less started in the 60s. So this is not that long ago. And when I joined cardiac surgery, and I joined at the time at the University of Vienna cardiac surgery, because at that time it was a completely exotic new field in surgery. We didn't have even the specialization in cardiac surgery because there were just a few. There was the first and only center in Austria to do cardiac surgery at that time. But if you look at the development, what you mentioned before about the interaction of neurosurgery and interventional radiologists and so on, what we see in cardiac surgery is a complete change in techniques and the fusion of cardiology and cardiac surgeons. It is more and more losing these divisions if you look at the Cleveland Clinic, they started quite some time ago that they only have a cardiac clinic and not a cardiology and the cardiac surgery department. They just have a cardiac department. Here in this hospital I'm starting here now in Guangzhou in China, together with UCLA, we're almost 1,000 bed hospital, so it's a pretty large thing. And I also only have a cardiac department and don't divide between cardiology and cardiac surgery anymore, because it's fusing more and more.
Yeah.
If you look at the heart valves, I mean, we had the greatest or the most important impact of new technologies, heart valve surgery. In countries like in Europe, like in Germany, more than 75% of all aortic valve surgeries are not done the conventional way by surgery, but by catheter-based percutaneous implants. That brings, on the one hand, look at Mick Jagger. Mick Jagger got his percutaneous valve like many others also. That's a fantastic new technology that reduces trauma, reduces hospital stay. I mean, to implant such a valve it's a short procedure. You could go home very soon after that. But what you also mentioned with the development of training of young doctors, we see now that young surgeons can't do any normal aortic valve surgery anymore because there are no patients to learn this anymore. So there's a huge change going on and a dramatic change of modern technologies, and we don't know where this leads to at the end of the day.
Yes, I agree 100%. In fact, you remind me of, do you know the Scott's parabola? If I can find it, do you see this little graph?
Yep.
Yeah, so I love this because some gynecologist a long time ago wrote a very short letter to the British Medical Journal, which has become very popular. So someone comes up with a promising idea. People think, oh yeah, possibly valuable, but maybe only research. Then there's the first few brave, encouraging reports, which generates enthusiasm. Then there's a bit of pressure, especially in the media, to take on the new technique. So there's a formal general introduction. It becomes standard treatment. Then people are starting to becoming doubtful, and then some damaging reports come through. And then there's the obvious medical legal case, the condemnation. Then it becomes a very highly specialized option and falls into disuse. And then nobody remembers that. And the funny thing is that 20 years later, someone will come up with the same idea and the whole cycle will start again. So I don't know if robotics is like that, but I'm sure robotics is not new. It's just that technology every 10, 20 years is better and similar ideas come through so that people want to sit here, have coffee and operate on the moon, you know, on the one astronaut who's super fit.
But you know how this robotic surgery started? I mean, I had the chance to see the first robotic surgery. It was in San Francisco in one of their research labs. And this was financed by the US Navy because they wanted to find a way how to deal with patients on the aircraft carriers far away. That's why these techniques started at the time. And of course, then the big business came and they wanted to put this into every hospital.
I know a lot of it is. I was going to say a lot of it is driven by technology in other fields. For example, some of the advances in surgery probably come from military technology that eventually is allowed to go mainstream.
Yeah. But your graphic, I love this graphic because it's so true. If you look at all this wave with so-called minimal invasive surgery and cardiac surgery, it's driven by the media. And then we see patients who insist to have whatever, a small cut. If you ask them, I mean, there's a 70-year-old guy. I mean, he's not going out for a wet T-shirt contest. So, I mean, but they are demanding this. And if you tell them, listen, I mean, this is, I mean, nowadays people accept bad results only because in the read in the newspapers you have to have a little cut. And I mean, this is a horrible development in many ways.
This is relevant to Gerhard's question on back pain, because I regularly get patients who come in with a newspaper leaflet that says, oh, you know, Linda from Devon went and had this fantastic treatment in some unknown Harley Street clinic, whatever, workshop. And unfortunately, there's plenty of people who want to take advantage of patients in pain, who are desperate for a quick solution, who will try anything because maybe mainstream medicine hasn't given them enough attention, or they think they haven't got enough attention and they still have symptoms. And there's a lot of, I would say, middle-aged charlatanism still around, especially for pain or even cancer. Well, you know, with treatments that are promoted, you can see them even in the newspapers or magazines sometimes. The other point that Roland made is the pressure from industry. Pressure from industry in medicine applies to every field. Sometimes it's pharma industry, pressure on which drug to prescribe. Sometimes it's surgical technological industry. So they guide a lot the discussions. They generate the pressure through social media. Everyone wants to have, as Roland said, the smallest scar, the minimally invasive access, without necessarily going through the right path of generating the data, having objective, non-biased assessment of the data, and then if that passes, then you offer it. So I think we as doctors are responsible to maintain that line and put, allow the industry in the conversations, because we need their research infrastructure, but at the same time, we should be guiding them, not the other way around.
That's right, but that's a problem of finance. I mean, I left the university a long time ago and joined private hospitals, and at that time I was in Germany. There was a Röntgenklinikum. At that time it was the largest cardiac surgery department in the world. We treated 12,000 patients in our department every year, so that was a pretty busy department. And we were the first hospital that went private, so you could buy, you still up to now, you can buy the stocks at the stock exchange. But that implemented that we were completely free from industry. At the university, if you want to attend a conference, and you have to attend conference because you want to present your papers, but nobody pays for this. And I mean, your income at your salary at the university hospital is not that good that you can pay 4 flights to the US from Europe every year, because I mean, then you can't feed your family anymore. And that's why you have to accept being paid by industry, which is of course corruption in some way, because then you have to use implants, because otherwise they don't pay your flight and so on. But the contrast to the private hospital was that we got everything paid from the hospital. So if I want to go to the conference, I got it paid by my hospital. I could tell to all the industry guys, listen, I don't want to need, I decide what implant I use and not use. So this made us completely independent, but this is only possible in private industry.
So I'm afraid, we can't always look at the good side of things only.
Can I ask you a question, Andreas?
Yeah,
I've written down, I think I've sent it to you in the email also. It's a completely different question, What I was thinking is, I mean, you essentially are hands on the brain all the time, yeah? I don't know. Okay, my question is the following. I mean, when you're operating on the brain or this, especially the brain, you're like hands-on the brain all the time. Huh? But the human brain is one of the most difficult things for us to understand, how it computes, and it's evolved for a very long time through evolution. And we had a number of the Trinity talks here. One talk was by Ramachandran. I don't know, you probably know him, who does a lot of work on how to understand the brain details of the brain function. And so it's one thing he mentioned is synesthesia, which I heard the first time. It's some people, when they look at numbers, 1, 2, 3, 4, 5, let's say printed in a book in black. No? I don't know about you, but myself, if I look at a book and it's printed in black and it says 1, 2, 3, 4, 5, then what I see is also all the numbers in black. Yeah, but there are some people who have a phenomenon called synesthesia who would see all the 7s red and the 5s blue. And the other day, I read a book about Feynman, Richard Feynman, the physicist, and he seems to have something similar to that. And I'm going to write an email to the author of that book, actually, to ask more details about it. And Feynman apparently had some similar phenomenon in the brain where he would see formulas, physics formulas in color, and he could manipulate them in the brain. Yeah. So, and the way I understand it about synesthesia is that it means that sections of the brain which for normal people are disconnected are connected for some select people, very small number, but they have these different ways of functioning in the brain. So my question to you is really, okay, if you extract a tumor, or like you take out a nail from the brain, that's a different story, really. But some of your work, does it allow you to learn about, the deep functioning of the brain, or by cooperating with people who look at the deep functioning of the brain, could that lead to new advances in research? Another talk we had is by Simon Baron-Cohen, who is a Trinity fellow, in autism, and he was talking about this empathy center in the brain, which has evolved over a very long time. And Ramachandran also talked about this empathy center. For example, I can see you sitting here now, and most people, the empathy center, if I see you with my eyes and there's something which hurts you, it hurts me also, So my question to you is really, how much of the internal functioning of the brain do you learn from your work on the brain?
Thank you, Gerhard. I always like your questions because you push us in two corners that we are not comfortable. And
that's exactly what I want to do. It's kind of, that's when we learn, when we are out of our comfort zone. Huh?
The truth is, as a neurosurgeon, I cannot pretend to be as highly evolved as Professor Ramachandran or Baron-Cohen, because they do different kind of work. They do, for example,
my question is really about the overlap of these specialities,
Yes. Well, we don't do that sort of work unless we collaborate with people like that. For example, a lot of the brain function knowledge became available because people observed the effect of specific damage to specific areas of the brain. So the lesioning type of observation. So let's say I I destroy area X and I see the effect, and therefore it means that X controls that. And then I do the same on area Y, and a different function changes, and therefore Y is involved in the other area.
Yeah, Ramachandran was looking at amputations, for example. A lot of his work is about this amputation, effect of amputation.
So we know the effect of certain lesioning type of connections because we have tumors in all sorts of areas of the brain. But the modern techniques allow a combination of, or a merging, if you like, of assessments. So we can bring imaging, we can do MRI imaging, we can do different type of MRI imaging. For example, if you look at Ramachandran's work, he has some functional MRI imaging where if you do this, a different part of your brain will light up as opposed to doing that with the other hand. And so there's, or speaking or saying the words hello versus thinking the word hello may activate different parts of our brain. So we have a lot of information from imaging, from functional imaging. And when I say imaging, I mean CT, MRI. So the static imaging, single photograph, single point in time, versus functional imaging, where you try to see what parts of the brain are activating with a particular function. If you throw into these cognitive assessments from neuropsychology, they are now, well, for long have been associated with these assessments. And then, you know, the neurosurgeon's role, it has been a bit on the sideline in providing the patients, in collaborating or being asked to do certain things. So we're not central to the understanding of this function. I think that's best served by neuropsychology, neuroscience, sometimes neurology, sometimes neurosurgery, and of course in collaboration with imaging. But it's at this stage there is not one field that can cover all that. It's now a puzzle. And again, going back to the funding, if you have good funding, you can have a lot of games and use all the patients that come through. You could send them next door and get them tested. But in reality, a lot of these are missed opportunities because there is simply no time and no funding. Mm-hmm. So still a lot unknown about the brain, especially to us. I mean, we don't operate on neurons or connections. You know, neurosurgery is still a macro, at the macro level. It's not a, you know, the magnification, for example, of a microscope is, you know, in the order of 30 times or plus or minus. It's not in the order of 1,000 times. And I wonder if in 50 years or so, they will be able to see so much better than what we see, and whether it would make a difference or not. Because sometimes when you operate on a microscope with very high magnification, your progress is too slow. You're focusing on a very small piece for far too long. And then you reduce the magnification and you see, oh God, I've been wasting time on this little bit. You know? So that kind of answers without answering your question, doesn't it?
Oh, it's a great question. Tom, you are a surgeon. You haven't talked yet. Do you have questions, Tom?
I do. I'm a little reluctant to ask it really, because it's such maybe a huge subject, but I just wanted to ask Andreas about regenerative medicine and spinal cord injuries. I was an owner of a DAXI. As you're probably aware, Dachshunds are very prone to invertebral disc disease, and one of our DAXIs had a very large lesion with a myelomalacia as well, which meant the cord degenerated. And I sent her to Nick Jeffrey at Cambridge, and he did placed some glial cells from the olfactory bulb, and with little effect as it turned out. But I was just wondering what the state is in human medicine about using progenitor cells for spinal cord injuries.
Thank you, Tom. That's the holy grail. I know that there is a lot of research going on, but none of it has really permeated to clinical work or routine work. It's just not been possible so far to translate any encouraging results from animals to humans. And if you look at basic science research in mice or rats, every few years there is someone reporting regeneration in spinal cord injured rats. But then when you try to do similar work or translate it to humans, it doesn't work. So there's something missing. There needs to be some paradigm shift in those efforts. So as far as I know, there is not yet been any successful use of these progenitor stem cells or the pluripotent stem cells alone. Now, having said that, in the news a few weeks ago, very few weeks ago, in fact, you might have seen some reports from Switzerland about paralyzed patients walking again after the implantation of a graft, but that was an electronic type of graft, not just cells, and they've only done it on a very small number of patients, but that is the first thing for many, many years that has allowed some hope in this. I think whoever manages to solve this will clearly help a lot of people and deserves a Nobel Prize, but God, it's been for years. And that was one of the reasons why I wanted to do neurosurgery. You know, in fact, back when I was at Trinity, they were trying experiments on implanting stem cells from aborted fetuses into Parkinsonian patients. Obviously, that failed. That's not done anymore because deep brain stimulation is much more reliable, and also there was no guarantee that. Can you imagine now having such a small sample, an aborted fetus, and within that you are looking for a structure in the brain that is only, you know, millimeters long in a human adult? Imagine how in a tiny source. So that kind of fell out of favor, but the technology, I guess, was translated into other things. But spinal cord injury regeneration has not yet happened, not really.
That's quite surprising, in as much as, you know, it seemed to offer quite a lot of promise. Well, yeah. Certainly speaking to Nick, but Nick Jeffrey was doing the research, and he obviously had some influence or some emphasis or some bias to suggesting that it was going to be maybe more beneficial than it's turned out to be. Not yet.
I'm still hoping it will be, but there is no biological treatment yet. This report from Switzerland 2-3 weeks ago is quite encouraging. But again, very early stages.
Thank you very much.
Yeah.
Okay, Roland, any more questions? Roland, no.
Yeah.
Yeah, any more questions, Roland?
A short comment. What Tom just asked about spine solutions with. I performed long time ago when I was young. I started with harvesting and transferring messenger RNA transcripts from human growth factors into bacteria. And I actually performed at that time the first experiments in humans where I planted this into the heart. In animals, we could prove that we can grow some sort of vascular structures to the heart. Our imaging technologies couldn't prove us anything in the heart. And of course, the patient refused that we cut out the heart for histology to prove any effect, of course. So that's, we only were stuck with the animal experiments. But I mean, with angiogenesis, there are a lot of also with new technologies which do not get any promising results up to now. Whatever we constantly read that people are culturing cardiac muscle cells or implanting stem cells, I do not see any real solution up to now in this field.
There was, I sent you the publication a couple of days ago. There was an experiment to implant a genetically modified pig's heart into a human. And I have a friend who is professor both at Tokyo University and Stanford University, who he is doing experiments on similar on transplanting sheep heart into sheep organs genetically modified into pigs to grow such organs in pigs. As he uses a sheep to pig model instead of humans. So there's work on that.
Yeah.
I mean, in our department, when I was in Cape Town in South Africa, long time ago, we implanted a baboon heart into a human baby, because otherwise the baby was dead, but the baby did not survive this anyway. So there have been a lot of these experiments have done that are ethically not really, or let's say questionable.
Yeah. But I think we're hopeful. Just like nowadays, a heart transplant is an everyday operation, I guess. It started somewhere. It went through a difficult phase. I think spinal cord regeneration, well, so far it seems not possible, but I'm sure someone someday will provide that paradigm shift. I think at the moment, certain things we keep trying the same way and it doesn't work. For example, with brain tumors, there is a type of brain tumor that you only get 1 year survival with it. There must be some paradigm shift that will come, hopefully not too long, and things will move in a different direction.
Okay, I think, Andreas, thank you so very, very much. I think you have to go to your operating room at some point so you don't get out of practice because you're not a university surgeon. Thanks so much. It's amazing. I mean, we met first time maybe 10 years ago, so next time meeting up in person should be shorter than that. So I'm looking forward to hopefully not on your operating table. But thank you so very much. If there are no other questions, so let's thank Andreas very, very much for your fantastic talk and presentation and explanations and discussion.
Well, I also want to thank you for taking time out of your busy schedules. It's always a pleasure to meet Trinity ex-Trinity students like we all are, and it's always even more pleasure to hear the questions from people in different fields, because this is how ideas are born, I guess. So it's a pleasure, and again, hope to hopefully meet sometime soon.
That's why I organized these Trinity sessions, because we always get very, very interesting discussions. Thank you so very, very much. Next meeting next week is actually by it's on the Ukraine crisis, which is a totally different subject. You're all welcome, of course. Okay. Bye-bye.
Thanks so much.
Thank you.
Thank you all very much. Thank you. Bye.
Bye-bye.
Thank you very much again.